differentiating between lumbar spine, SI joint, and the hip. So we know sometimes it's confusing to differentiate them. So from the subjective history, what are the signs that help you to differentiate?
You know, the biggest thing there, I think, and I always try to push this, you know, on courses, is early on, you need to look and do a very thorough job of establishing the body diagram. And so the body diagram is probably your first best indicator that you may, you know, have some information from, which means, okay, so if you're looking at SI joints, and then you consider hips, and so you have you could have you have a bilateral, or you have two of those things to consider. Those usually have symptoms that are unilateral. So you'll see something on one side versus on both sides, or certainly not in midline. So if you go to a lumbar complaint and you say, okay, where are your symptoms? Commonly, they're going to tell you where they hurt the most or have the most symptoms, which is, okay, let's say right side, low back. Okay, well, first thing that pops in your mind, I can remember back when I was out of school, first thing I would think is probably SI, because that's where it hurts. But then if you ask the next question, is like, is there any problem with your left side? You know, most people will discount the left side because it doesn't hurt as bad as the right, and they want you to know the right hurts. And so it's like, but it does. And so it does cross midline. So right there, first and foremost in the body diagram, I would say, listen, lumbar pain can be at midline. It can be bilateral. So if you really do a thorough job of establishing the body diagram, I think it will eliminate some of the early confusion of, is this really, and could this be an SI? Could this be a hip? Now, could you have bilateral SI problems, or could you have bilateral hip problems? And in 25 years of being a therapist and doing this at a decent level for, I think, most of those, I hope. Yeah, sure, I've seen a couple of those, but it's not the common theme, right? So you go with I always tell people there are very few zebras, right? So don't look for zebras, look for horses. So go with what the odds are best likely. And so midline and across the back, bilateral complaints tend to be lumbar. So that would steer your questions and thoughts there. And if it is truly unilateral, and you do establish that it is unilateral, then maybe there is some further consideration there for an SI or a hip problem. And so, yeah, that's where I would first start at, eliminating those things or considering those things. Other things to consider, again, going back to the body diagram, is doing a real good job of establishing if there's any distal symptoms. Below the knee is a little more rare. Again, we're talking horses here, not zebras. And so below the knee, I would, lean more towards a lumbar complaint versus a hip or an SI, just from the referral pattern, because you can't have a radicular symptom from the lumbar, and you're not classically going to have that symptom from SI or hip. And then certainly into the foot or any numbness or tingling, right? So those things would, again, steer you towards lumbar versus it being a hip or SI. And so I feel like that's important. And I think that a lot of early clinicians that don't have the time and the experience sitting in with patients and establishing the body diagram, they don't do a great job at doing that, because they don't want to ask the next question. The next question, they feel like they might be badgering the patient a little bit, and I think it's important, even the subtle things that they may not feel like is important or may not feel like is associated to their complaint may very well be a big part of their complaint. And so I say lots of times, if they go, okay, I go back to my right low back. My right low back is bothering me. So you color that in, and you say, is there any other areas, that you had trouble? And they go, well, have a little bit of pain in my thigh. Okay, well, now the thigh. Okay, does it ever go below the knee? Well, one time last week, I think I felt some things. So then all of a sudden you go to your Treat Your Own Back book and you open up the, a centralization page, and now your body diagram has changed entirely. So your consideration has changed entirely. So I think it's important to do that. And so then considering, the bilateral, midline and bilateral, below the knee, foot type symptoms, those type things are really strong indicators that you're looking at something lumbar versus the hip and SI. Let's see, what else have I got here? And I guess in history, since you're specific with that, at onset, I think with, and this is again, something I feel like I lean on a decent amount. especially when someone's maybe comes into the clinic thinking SI joint, is how did it start? And so typically, if you're going to see that, there's going to be a high prevalence, I think, in that population, if they truly are, to have had some sort of trauma in their past, be it a fall, be it an accident, or maybe they've had some recent, either they are or recently have been pregnant. And so those things, those events like that make that potential of an SI greater. And so, okay, now I'm at least listening, to that, especially with a body diagram that suggests it could be, right? So,
yeah.
And so that's, those are some of the big key things there. I think with lumbar and with hip for sure, you'll see a little bit more of an insidious onset. So if you ask someone how did it start, I guess classically you look back and the vast majority of those are going to be, they're not sure, or they may try to come up with a reason why it might be, but it's not really the true cause and effect.